Hi and welcome. So today we're here to talk about recurrent pregnancy loss. And we're very happy and excited to have Dr. Lora Shahine. Dr. Lora Shahine is a board-certified reproductive endocrinologist who practices at Pacific Northwest Fertility, an IVF specialist in Seattle, Washington. She's the director of the Center for Recurrent Pregnancy Loss and is committed to providing excellence in patient care. She teaches healthcare providers about fertility and recurrent miscarriage. She is also passionate about writing and is a regular contributor to blogs such as Huffington Post and has authored 2 books. In 2017, she published Not Broken, an approachable guide to miscarriage and recurrent pregnancy loss. Her website is listed here, lorashahine.com, and among other features contains a robust blog with helpful articles for clinicians and patients, not just on recurrent pregnancy loss, but fertility in general and preconception principles. So welcome, Dr. Shahine. Thank you so much for joining us today.
Thank you for having me, Monica. I'm excited.
So why don't we start with just the definition of recurrent pregnancy loss? What is the definition, either ASRMs or ACOGs, or as we'll discuss, ESHRAs, of recurrent pregnancy loss, and how do you define it?
Absolutely. So this is something that different groups, have different definitions. But in general, in the United States, the American Society of Reproductive Medicine is considered to be the expert group when it comes to first trimester complications and miscarriage. And they put out a definition of recurrent pregnancy loss in 2012. And they say that recurrent pregnancy loss is a disease distinct from infertility in which there are 2 or more pregnancy losses. And when they gave out this definition, they were very careful to say what they believe a pregnancy is. And they define a pregnancy as a clinical pregnancy loss, meaning the pregnancy gets far enough along to see something on ultrasound or to have a tissue diagnosis. And so someone who's had 2 or more clinical miscarriages is considered recurrent pregnancy loss. And that's very important. And that was a very big change because it allowed for more people to get evaluation and testing. Before, and when I was going through training, it was very strict that someone had to have 3 or more miscarriages in order to see a physician or have testing for miscarriages. And so that was a big change.
And in terms of clinical pregnancy rates, we know that some of our patients who've had, let's say, multiple chemical pregnancies still might maybe find this definition somewhat lacking.
Absolutely. That leaves out a lot of women who are having these biochemical miscarriages, a positive home pregnancy test or a positive blood test and then a late period. They don't get to the point where you can see anything on ultrasound or test tissue. And this definition by ASRM really does leave out a lot of women. But ESHRI actually updated their guidelines in November 2017, actually after I published my book. And they include biochemical miscarriages as a part of the definition of recurrent pregnancy loss. And so in Europe, it's people often will get evaluations sooner, even if they're having these biochemical or very early losses.
So that's a notable and important difference. And we'll include that link here in the transcript. But I do think that many patients who have that loss and have had an emotional investment in that pregnancy might find some comfort that then it's justified that they get an evaluation.
Yeah, absolutely. People often come to me and say, my provider wasn't willing to do testing until I had 3 or more miscarriages. And that is definitely what was the standard thinking when a lot of us were going through our medical training. And that is really, considered the standard by a lot of people still, just because that's what they learned when they were going through. But even before ESHRI came out with that definition, in my own practice, I really do testing on people with 2 or more losses, no matter how far along. I think from an emotional standpoint, I mean, even just a period without a positive pregnancy test feels like a sense of loss and grief. And so trying to tell women that a positive pregnancy test in the late period or biochemical is not a pregnancy loss is very dismissive. And it doesn't mean that you have to do testing, and it's okay to listen to patients and talk them through different definitions. But, before the ESHRE study came out, there are a couple of studies that have shown that women with early losses still have the same number of issues as far as anatomical issues or hormonal issues that women with later losses do, and that women who have early losses are at the same risk of having a subsequent miscarriage. And so even before ESHRE came out with that definition, I felt that there was evidence to really support doing an evaluation sooner rather than later.
So important. So let's talk about what that evaluation would entail. Once diagnosed, ASRM suggests certain testing be performed. I find that what testing is done is often center specific though. So what are the guidelines and what do you do in your practice and why?
Sure, absolutely. So ASRM is very clear about what they recommend, and they go through a lot of other testing and say that evidence really doesn't support it. What they do recommend is an anatomic evaluation. So looking at the uterine cavity to see if there is something that might be affecting implantation, something like a uterine septum, which is a fibrous band of tissue kind of in the middle of the uterus that someone's born with, or something that could have developed over time, like a submucosal fibroid. Fibroids are common, and most fibroids do not cause miscarriages, but if there's a fibroid inside the uterine cavity where an embryo would implant, that might cause miscarriages, and it's something to evaluate further. So anatomic issues is definitely recommended. The one immune issue that's recommended is looking for something called antiphospholipid syndrome, and that's looking for certain antibodies in the system that really shouldn't be there outside of pregnancy. It's a simple blood test looking for certain antibodies. They do recommend looking at some hormonal issues like thyroid, thyroid function, and to consider looking for thyroid antibodies, although the evidence is varied. Looking at prolactin, because prolactin, if it's elevated, it could cause implantation issues. And screening for diabetes, looking for hemoglobin A1C or someone's blood sugar control over the last couple of months. It's really rare to find somebody with diabetes, but it is an independent risk factor for miscarriage. And then the one genetic issue or blood test that's recommended in both the female and male partner is a karyotype, and that's looking for something called a balanced translocation, which is a rearrangement of chromosomes in the people that are getting pregnant, so either the female or male partner. And it doesn't impact the health of the people that are getting pregnant, but if they have this balanced translocation, they are at higher risk of having miscarriages. So that's something to look for too. So anatomic issues, hormonal issues, the one immune issue, antiphospholipid syndrome, and then a balanced translocation screening test, which is called a karyotype. That's what's recommended by ASRM.
Okay. And is that what you do?
It is what I do. Yeah, the things that I do that are outside of the scope of or the recommendations from ASRM are I do ovarian reserve testing, and that is not recommended by ASRM or ESHRE. That's the European Society of Reproductive Medicine. But I really do find that it helps guide counseling and options. And I think that no matter how old the woman is who's getting pregnant and trying to start her family, I think it's important to know what her ovarian reserve is, because that might really guide choices that she makes. And I see in my own practice an association of diminished ovarian reserve and recurrent pregnancy loss. And I really think that that's associated with egg quality. And sometimes recurrent pregnancy loss is one of the first signs that someone has poor ovarian reserve. because if we're conceiving with eggs that aren't able to do all the genetic changes that they need to, that is a higher chance of the pregnancy having a chromosomal issue, which is, the most common cause of first trimester miscarriage. We do all of this testing, looking for anatomic issues, looking for hormonal issues, really trying to find that silver bullet that patients want. They want that answer. But before I do a single test, I say, listen, 50 to 75% of the time, I do not find an issue in the people that are getting pregnant, because the issue is in the embryo. And we really can't test that unless we can test it later after the pregnancy loss. And so, that's something that I see in my own practice. I often will do semen analysis, although there is nothing in a semen analysis that's going to predict miscarriage. Again, I'm just seeing people that are starting their family and thinking about options. And sometimes if I find a male factor, that might guide choices.
And if a couple or a patient, when they arrive, says that my friend or I read on the internet to do this certain test that's outside of the suggested test, what would you say?
Absolutely. So we talk through it. And like a very common one is, I'd really like to do natural killer cell testing. I read a lot about it online, and my friend did it. And so the evidence really does not support that the level of natural killer cells in your bloodstream is associated with a level inside the uterus. It's not consistent. Natural killer cells are actually very important for implantation. They have this awful name, and it's really easy because you want to find something that's wrong, and you want to treat something and take an action, and do anything you can not to go through this pain and that loss again. But really, the natural killer cell testing does not predict somebody's next miscarriage. And the treatments for it, quite honestly, have some harm. The focus is that natural killer cells, if the levels are elevated, then you need to, suppress the immune system. And there's some pretty strong medications that I see people taking, like very high dose steroids and intravenous intralipids, and IVIG, which is intravenous immunoglobulins, which is, like getting a blood transfusion from, hundreds of people, because they have to isolate all these immunoglobulins. And, I actually really try to not use the word immunosuppression. The immune system is really important, and it's hugely important for implantation, and our immune system has to shift to a more receptive state. But I don't want to focus on suppressing it, because there's, implications and can be some harm to the women that are taking these pretty intense treatments.
Absolutely. And not cheap.
No, exactly. I know. And it's such a vulnerable population. People want an answer, and they want to take really, divisive steps towards decreasing that risk of miscarriage. But I want to keep people safe. And I think something that I just say over and over and over again is, really most of the time it's that unique embryo and the way those genetics came together. And each time someone gets pregnant, it's a new chance. It's a brand new egg. It's a brand new sperm. It's a brand new uterine environment. And I try to get people away from feeling broken. I mean, that's the title of my book. You're not broken. Mm-hmm. Let's learn about this. And, a wonderful study and every, talk that I give, I always show this slide. It was by Brigham et al. It's from the early 1990s. We'll never get a study like this again. It just looked at about 250 women who had had a number of miscarriages. They didn't do any intervention whatsoever, not even aspirin, not even progesterone. They just sort of watched these women and said, what happened in their next pregnancy? And in their population, even when a woman was 40 years old and had 5 miscarriages, in her 6th pregnancy, she had a 50% chance of taking home a baby. So when I see people, their narrative and their story is usually 100% miscarriage rate. They're coming to see me because they haven't been successful. So they feel like that is their story. But I want them, I want to do testing and I want to make sure that we're not missing anything that we can intervene on. But I always want to remind them that even if I don't do a single test or a single intervention, the next time they have a pregnancy, it's a higher chance of being successful than not. And I really want people to feel that hopefulness and try to regain that if they can.
I mean, so important for us as nurses to know. So we talked about kind of what not to do, or not recommended, I guess I should say, in terms of natural killer cells. We talked a little bit about just what you said, expectant management, which is, I think, a little difficult for patients because they just want you to do something. But when given to them in a way that they really feel like, maybe in the context of that study, that if they keep trying, it can work, would be helpful. But what, if any, are treatments for recurrent pregnancy loss? Let's say you found one of those issues that you discussed previously was abnormal.
Sure. First line is if we find an issue, we treat it. So if we find an anatomic issue like a septum, it's a very simple surgical procedure with a hysteroscopy and just kind of placing a small camera through the cervix and just gently snipping away that fibrous tissue to increase the chances of the successful implantation in the next pregnancy. If someone has a hormonal issue, addressing that. So if they're hypothyroid, giving them thyroid hormone. If someone is diagnosed with antiphospholipid syndrome, which actually has very strict criteria, it has to have elevated antibodies, more than 12 weeks apart, and very strict clinical criteria in that it's supposed to be, 3 clinical miscarriages in the first trimester, or a single late loss after 10 to 12 weeks of pregnancy. So very strict criteria, but the first line treatment for that is really aspirin and maybe heparin or Lovenox with pregnancy. It's funny, you think about those things as actually decreasing blood clots, but when you're using it in the context of antiphospholipid syndrome, especially in the first trimester, you're really, and aspirin too, you're really trying to shift the immune system to a more receptive state that actually helps progesterone kind of do what it's supposed to do. People with antiphospholipid syndrome do have a higher chance of blood clots in later pregnancy, like in the second and third trimester. So in later pregnancy, that's what the treatment is for. But first trimester, it's really trying to help with implantation, which is interesting. And if someone has a balanced translocation, so one of the partners, has all of the genes that person needs to be a healthy reproductive adult, but just 2 of the chromosomes had kind of exchanged material, while they were, egg and sperm kind of in their mom, at the very, very beginning. Then when they go to make gametes, like whether it's women making eggs or men making sperm, it can be half to 75% of the gametes are going to be missing large portions of their DNA. And so not all of the gametes are affected. So if someone has a balanced translocation, then options are to continue to try, because they very well in the next pregnancy could, conceive with a sperm or egg that has a perfect genetic component. Or they could be more proactive and, screen embryos for chromosome content. And that requires IVF. And, but really, truly, the most common conversation that I have is with couples that have done the testing and we don't find a reason. And we really are assuming that it's a genetic issue or a chromosome imbalance in the embryo. And that the discussion is really, okay, are we going to try again naturally, with expectant management and just really good supportive care in the first trimester? Or are you going to consider doing IVF as a way to screen embryos and maybe decrease your miscarriage rate from aneuploidy or chromosome imbalance in the embryo?
Makes sense. Just to touch on Lovenox for one quick second, because we as nurses have seen this given at different times. So sometimes it's given around the time of transfer, sometimes with first pregnancy test, sometimes after the levels are rising. So it sounds like you and your center use it with the first positive beta.
It depends, and the studies and recommendations really vary. I actually know a lot of maternal fetal medicine physicians that wait until after intrauterine pregnancy is documented. So even after like 6 to 8 weeks. So it really is practice dependent.
Yes.
If someone is doing fertility treatment and I know when the embryo is going to be transferred, I often start it a couple of days before the transfer. But if someone is doing expectant management, we wait until there's a positive pregnancy test. And it really depends on what they're using it for, and whether they have a history of blood clots themselves, or whether it's just because they've had miscarriages and some elevated antibodies. And I work with a hematologist that's really helps with the care plan.
That sounds great. So what can we do? I mean, I really struggle as a nurse properly, I feel like, supporting patients with this diagnosis. Dealing with a pregnancy loss is tough enough. It can generate emotions like anxiety, frustration, sadness. What do we say to a patient who just lost another pregnancy? And what are small, everyday ways to support patients, like little tweaks that we can help with the people with this diagnosis?
Yeah, I think that emotional support and recognizing the emotional impact of recurrent miscarriage is hugely important. And the ESHRI update in 2017 actually spent a lot of time going over the important psychological impact of miscarriage. And I was really happy to see that paid attention to so much. I think one thing is really education. I remember very clearly when I was really starting to care for patients with infertility and miscarriage, calling a patient with positive data and, being excited and saying, hey, you have a positive pregnancy test, and this great, and just absolute dead silence on the phone. And, she sort of said, thank you so much, Dr. Shahine, but this is really just the beginning for me, and actually hung up on me. And oh my gosh, it was such an eye-opening experience to realize that, for her, a positive pregnancy test, the joy had been taken away, and it was really just the beginning of angst and worry. And so I think that awareness is really important. I think that educating people on how to give bad news is really important. And I think you've done a great job of that in the newsletter. And I think there's a lot of really good resources for that, kind of talking about, how to plan for if it's going to be bad news, who to hear it from, and how they want to hear it if they're going to have bad news, like falling betas, or, that they're going to come in for an ultrasound and it might not look good. And just really providing resources for patients. There's excellent resources on resolve.org. In Seattle, we have a couple of group, therapy sessions run by patients for patients. Some are with Resolve, some are with the Children's Hospital here, some are through churches that people don't have to be a part of that community. But there are so many wonderful support systems, and it's important to help people find the right one for them.
And can you tell us a little bit about your book?
Absolutely. The book is titled Not Broken. It's a patient-centered, I call it an approachable guide to miscarriage and recurrent pregnancy loss. And I really just wanted to have a resource for people that was readable and balanced. And so I kind of go through definitions because it's really hard when people get information from doctors, and even when they get a medical bill and it says the word abortion on the medical bill, and it's just so emotional. Like, that is a medical term that the pregnancy didn't get a certain amount along, but the patients just get really flustered, and kind of, I want them to be aware of the medical terminology. And then I go through a chapter just on testing and, what ASRM recommends and what's controversial. And I have a whole chapter kind of on the immune testing and treatment. And I really try to talk about evidence and sort of say, there are cases where some people might do this treatment, and you really just need to think through the pros and cons and understand that every intervention has a potential harm. And I try to be very balanced. I have a whole chapter on men. I call it sort of the other half. I wish there was more testing. They're half of the genetic equation. But there's really, we're getting there. We're starting to pay more attention to the male factor in fertility and miscarriage, but they really have been ignored up to this point. That's just a society sort of biased, and a bias in research funding that I hope is going to change. And I really do talk a lot about the emotional impact and trying to build the resilience to keep trying. When I have patients, that stop trying, which happens, I really just try to check in with them and make sure that it's because they really have changed their life goals, but it's not that they've just lost the ability to keep trying. So helping people find the resources to help them be resilient and keep trying, if that's what they want to do, is one of the most important things we can do as providers.
I mean, it sounds like a great book, not just for patients, but for all of us that work in an infertility center needing to support patients. So we will put a link on the newsletter for that. And thank you so much for joining us today. This was so incredibly helpful. I feel like this is going to be valuable to all of us in all of our practices. And honestly, not just for recurrent loss, but even for recurrent negative pregnancy tests in terms of support and resources. So we really appreciate you coming here today.
Oh, thank you so much for the opportunity, Monica. I really enjoyed it.
Thank you so much.